Welcome to another AMA Steps Forward Innovation Academy webinar presented by the BHI Collaborative. The Collaborative is a collective product of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person integrated and equitable approach to physical, mental, and behavioral health care. We are committed to ensuring a professional, satisfying, sustainable physician practice experience and act as a trusted partner to help physicians and their care teams overcome the obstacles that stand in the way of meeting their patients' mental and behavioral health needs. This webinar is titled, How Integrated Behavioral Health Care Can Strengthen Value-Based Care. Before we get started, please note this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute an endorsement or warranty by the American Medical Association. If you have any questions or concerns, please contact us at practice.sustainability@ama-assn.org. In this webinar, value-based care experts will explore how healthcare organizations can leverage behavioral health integration within their value-based care arrangements to further their goal of enabling evidence-based, preventative, equitable, and coordinated whole-person care. Experts will discuss how VBC arrangements are currently in BHI, as well as persistent challenges and opportunities to further enhance a practice's or system's overall VBC success. So without further ado, I would like to introduce Dr. Carolyn Carney, President of Behavioral Health and Chief Medical Officer at Magellan Health, and Dr. Maria Wilson, Executive Medical Director at Oak Street Health. Welcome to you both.
Thank you.
And before we get started, I just wanted to quickly run through the learning objectives for today's discussion. So in today's discussion, we will describe what VBC is and how it differs from fee-for-service. It'll help you understand the current challenges within value-based care arrangements and how behavioral health integration can help. And we will also explore what the future of value-based care and behavioral health integration could look like. Now, to level set, Dr. Wilson, can you give us an overview of what we're talking about when we say value-based care? I know everyone has a slightly different interpretation of what that is. And what does value-based care look like at Oak Street Health?
Thank you, and thank you for having me on today. You're exactly correct. Value-based care is a term used to describe healthcare that is designed to focus on quality of care, provider performance, and the patient experience. The value in value-based care refers to what an individual values most, which is their experience when they go in to see their clinician, and the outcomes that they have. Is their condition being managed in their eyes optimally? Value-based care is patient-centered and coordinated care where the clinician commits to delivering a higher standard of care, reducing fragmentation in their health system, the healthcare system that they are working in, and they are evaluated on their quality of care, individual health outcomes, and this allows for greater flexibility in their ability to deliver efficient and equitable care. There are different flavors of value-based care. The four most common big groups are going to be performance-based payments. Others that you may have heard of are bundles payments or shared savings and risk payments and global capitation. And then there's obviously lots of in-between mixes and matches of those big common types that folks have kind of put together. Next slide, please. In a climate where hospitalizations accounted for greater than 60% of Medicare expenditure, while primary care spend is only about 3%, Oak Street Health, who I represent today, has chosen to, what I like to say, aggressively manage health in our communities. And so as a value-based care entity, we proactively manage health in the communities we serve by investing 3 times the average on our patients and deliver this health through our care model. In order to, we do this in order to reduce or remove those more reactive costs like hospitalizations. And we've noticed that we can then reduce hospital admissions, ED visits, and 30-day readmission rates. But who are we? Next slide, please. Oak Street Health is a patient-centric network of outpatient primary care centers for older adults. We have greater than 200 centers, and we have more than 270,000 patients that are served or receiving care in those centers. And this is delivered by 7,500 Okies. Next slide, please. We started 10 years ago in Chicago, Illinois, and now have spread to 25 states, and we continue to grow. We choose to serve communities that historically have been under-resourced, and our patients have had very complicated relationships with healthcare. Trust is a big issue in the communities that we serve, trust in the healthcare system. Whether these relationships or this lack of trust has been driven by historical context culturally or psychosocial issues, socioeconomic issues, these communities and patients therein have not been regularly engaging with primary care. And in fact, many of them utilize their local EDs as their primary care. Next slide, please. So our patients are complex. We believe that optimizing their health requires a different approach than your traditional fee-for-service model. So we've created a model that really strives to treat the patient more holistically, breaking down those silos, reducing the fragmentation that we all feel in the current healthcare system, healthcare environment. Our model is next slide. Our model is a high touch model with patients being seen on average 9 times a year. In order to pull that off, we have to keep our clinicians panels small. So we max out at around 500 patients on a clinician's panel compared to what we traditionally see of 2,000 to 3,000 on a fee-for-service clinician's panel. We've carved out indirect patient care time to ensure that our teams have dedicated time to proactively plan care and coordinate care with the entire team. We've also built a proprietary tech platform optimized to run our model, and all team members work out of this platform that we call Canopy. Next slide. And as you can see, these are the team members that we rely on a daily basis, and we keep patient care at the center of everything that we do and how we approach what we do on a daily basis.
That was an excellent explanation. Thank you so much, Dr. Wilson. So Dr. Carney, now to you. Magellan has a slightly different approach to value-based care. Can you give us a brief overview of who you serve and the models and arrangements that you all use to deliver that care?
Sure, I would love to, and thanks for hosting this very important topic today. I'd like to first digress into explaining what Magellan Health is. We are a company that largely delivers not only behavioral health benefits for other payers like health plans, states, counties, the federal government. We also engage in direct delivery of behavioral health services to individuals who need them in a variety of settings. We have 4 divisions sitting underneath Magellan Behavioral Health. The first is our federal division that contracts directly with the federal government, largely military services and other agencies. And we provide a range of services, including direct counseling to individuals who live on bases all over the world. We also provide resiliency training and fitness readiness training for soon-to-be soldiers, and a variety of other traditional EAP services for folks in the federal government or related to the federal government services in some way. We have another division, our public market division, where we contract directly with states and with counties to deliver their behavioral health benefit. And more than just deliver a benefit, pay claims, create a network, we actually partner side by side with those states to develop programs and bring programs forward. We are in major implementations right now with one of our states to completely reshape the way that behavioral health care is delivered and paid for in that state. So it's super exciting stuff that puts us in line of sight with getting the best care to the members who need care, as well as working with providers to really get that best linkage for individuals who largely are covered by Medicaid or those dual eligibles who are covered by both Medicare and Medicaid. Our employer organization, the third in these, delivers traditional EAP services largely, but also brings along special programs for individuals who utilize EAP services, and in some cases manages the full behavioral health benefit for large national employers. And finally, our health plan division serves other managed care organizations. So for instance, we may deliver all of the behavioral health benefit from utilization management, case management, network, claims, call centers, all of those sorts of things for a health plan. Or we may deliver very special programs around managing the child with autism, or putting in place suicide prevention programs, or programs designed to support evidence-based prescribing for persons with behavioral health conditions. So there's a wide range of services there, but they all are in service of a health plan in some way, shape, or form. So with that background, in many of these cases, Magellan itself is in risk-based contracts with some of those payers. So we take the risk and ourselves are in value arrangements with those states or those counties or those health plans. Downstream then, in order to ensure that we're bringing the highest level of services, we create value programs with provider organizations and other organizations that we contract with to develop those behavioral health services and deliver those services forward. So those might be, using some of the models that Dr. Wilson described, the upside relationships where there are incentive payments to providers. They may be bilateral risk arrangements in providers that are more mature in value-based programming and value-based contracting, or some ilk in between, as she was describing. We're really proud of that work. I hear over and over again that it's impossible to have value-based contracts in behavioral health, and I would say that's absolutely not the case. In fact, a year ago, we had a large press release about our value-based program, which is year by year maturing over time.
Well, thank you for that.
Sure. And I guess I didn't refer back to this slide. I do want to talk about Magellan's network and what some of those end targets of value-based programming might mean. Mm-hmm. So the first on the far left of this slide is just our general network, where we network with therapists and prescribers, whether those are psychiatrists, nurse practitioners, whoever it might be in that large network. We also bring to market digital solutions in therapy, like our evidence-based digital cognitive behavioral therapy models. We create specialty networks like those, say, for ABA providers to deliver high-quality services to children who need those services. We've developed a prompt care network to ensure that individuals who need care within 24 or 48 or 72 hours have providers who are willing to jump up and deliver that care and go beyond the longer waiting lists we see, given the extreme provider shortage in behavioral health today. We also created our own clinic called Magellan Provider Services, in which we hire therapists to deliver telemedicine services for our members across all of our lines of business. And we're also actively implementing the full collaborative care model that originated out of the University of Washington, with practices in places that might be unexpected, like inside a university setting, but also in more expected places like federally qualified health centers. Next slide. And I already kind of talked about this, but I'll backtrack a little bit to just say in 2022 and in 2023, we delivered $1 million in that upside bonus program for our providers. And I talked about that press release. In 2023, we went with upside for facilities and residential treatment centers. Those RTCs were among the first in the country to engage in these kind of programs. And then this year we went with both the upside and the downside deals with those same kinds of facilities and RCTs. We bring these disruptors to the market, and work with those disruptors in the digital or clinical space to not only fill in network holes, but also create different models of care for which we can then put those disruptors in value programs as well. Next slide. And then this approach, and I'll build on something that Dr. Wilson said, it starts with a very strong analytic approach. We have to have data. And I'll talk about this later this morning, but we really have to have data that is measurable. You have to take the emotion out of that equation. As a provider, I often feel like my patients are the sickest and I should, receive more value, but data may tell me otherwise. And so that's a critical part to this. And then we tier and we rank providers in two ways: against national standards that may be published standards. So average length of stay, say, as published by ASAM guidelines or the MCG guidelines, but also against the local market. So that local market presence has a role here because healthcare isn't delivered the same way every place in the country. And then we create coaching, we give data back to those providers, and we create stretch goals for those providers. Next slide. And this is just a quick example of our dashboards. The providers, I can tell you, absolutely love receiving these data. And to see the data, to take that emotion out, drives the change that we want to see. Next slide, please. And collaborative care, one of those models. I won't go deeply into this, but we really are doing the work of bringing behavioral health care to support primary care and other medical settings, and having timely, evidence-based, measurement-informed care delivered to their members, taking that pressure off the primary care provider to be able, to take care of that patient fully and have the right kinds of supports that they need to deliver that evidence-based care. Next slide. Collaborative care addresses many conditions. We go down from no conditions at all, no interventions needed, to those where ultimately the cases may be severe that we know we need to facilitate a transfer to get them into the care of the right type of behavioral health care providers. We focus on depression, anxiety, PTSD in these clinics, and we also use this program for kiddos, which is huge given even a worse shortage of child psychiatry and child therapists. So this really helps crack the nut in some of the access and availability issues we're seeing today. Next slide. And then finally, team-based approach. Where it says PCP, go ahead and put any provider. Maybe it's a pain clinic, maybe it's an OB-GYN clinic, a care manager that Magellan brings and is linked at the hip to the PCP and our psychiatrist. We use data support and technology support to fuel this program from a company called NeuroFlow that brings in the kind of technology that allows us to simplify the program, easily communicate, get information into EMRs, and that makes it much easier to scale. It's also really critical that providers know that we are not coming into a setting and saying, it's our way or the highway. We actually will even sit in clinics to watch how the clinics are working and how the flow of patients works through the clinic so that we can integrate into how the clinic does it, not how we do it. Next slide. And then more data. So the kind of data that we get back is measurement-informed care data and tells us how folks are doing over time. These data through that NeuroFlow technology can then integrate into EMRs. And our provider, our psychiatrist sees it, our care manager sees it, the primary care doctor sees it. So everyone operates with the same set of facts about how that patient is doing. Next slide. And same tool, a lot of stuff here that I won't go into, but it's important also that the patient has that data so we can push out all kinds of information seamlessly to that patient in a way that really facilitates their care and gamifies or uses behavioral economics to really engage those members. Next slide. And I will turn it back to you.
Great. Thank you so much, Dr. Carney. That was a really great overview of everything that you all are doing and all of the spaces that you're working in. Now, this question is for both of you. How do each of your organizations engage in behavioral health integration and enhance your value-based care efforts? So why BHI to enhance value-based care? And Dr. Wilson, let's start with you.
Okay. Well, we can all agree 2020 was a really rough year, and the subsequent couple of years after that, and we're still recovering from that. But in 2020, 1 in 5 U.S. adults experienced some mental illness in some fashion, some form. Greater than 17 million adults who identified and sought help experienced delays in care, whether those are cancellations or just delays in getting appointments to get in to see somebody. In the primary care setting, roughly 75% of our visits include mental or behavioral health issues or conditions. In the communities we serve, those numbers are quite high. I would venture a guess probably higher than that. Addressing a patient's mental health condition has been shown to positively impact the total cost of care and improve an individual's physical and mental health. At Oak Street, we do universal screening for depression and substance abuse. In 2023, we screened 90% of our patients for depression and 88% of our patients for substance abuse. Of those we screened and thought would benefit from additional care, 65% of them enrolled in services with our behavioral health specialists. 67% of those enrolled completed at least 6 weeks of treatment, and we saw significant reductions in depressive symptoms in our model in those folks who had participated for at least 6 weeks. Next slide, please. What we have also seen, we can probably go to the next slide, I apologize. What we have also seen in our model, in those who participated, in those enrolled, is decreased ED utilization by about 69% and a 50% reduction in PM total spend on med cost for those that are enrolled. Additionally, we've seen enhanced treatment plans and med adherence across both physical and mental conditions, and improved diagnosis of physical symptoms with behavioral causes. By having these services integrated into their care and how we assess, evaluate, and manage them in center, it also reduces the stigma of mental health, because they don't have to now go outside of our walls to go somewhere else and seek care. It is part of their routine visit that we make sure we assess, we evaluate, we follow up, we help them understand and help them manage when they come in to see us for their primary care. It also, and because of that, it enhances their experience and their satisfaction scores. But also importantly, it has increased provider satisfaction because of the built-in support and resources that help them manage our very complex patients. At least when I was coming through in training, our training is not very robust when it comes to helping us understand and manage mental health conditions. So when we are able to place these resources around our clinicians, it empowers them to do what they really want to do, which is manage our patients very holistically, and we can make them better, and by them being better at it and more comfortable, it helps our patients out after all.
That's fantastic. Great. And Dr. Carney, how about you? How about at Magellan, how is it enhancing your value-based care efforts, engaging in behavioral health integration?
So going back to some of the comments I made earlier on the collaborative care model and those stats I think Dr. Wilson referred to in the impact study on her slide as well. By developing the collaborative care program and being able to roll that out, I think that it's bringing more value in integrating with health plans' efforts to address depression, anxiety, and substance use disorders. So it's really part of what we're doing to bring value forward to those plans. Internally at Magellan, we know that if a care manager introduces the concept of using a tool that we can track and communicate to members, we can get, after discharge from behavioral health hospitalization, about 76% of individuals accepting that because of that relationship. So we really target individuals who are at higher level of need, those who have been in residential treatment or those who have been in inpatient treatment. Why is that important? I'll go back to the stats that Dr. Wilson mentioned. It's important because many of those folks are going to fall out of the behavioral health system and land in primary care. By using tools to help track them and find them over time, we can keep that behavioral health care better integrated with those individuals. The other area where we have been working is to develop models where we can specifically work with individuals with serious mental illness to take on total cost of care for caring for that individual holistically. If I look at data set after data set in the country, it doesn't matter who the payer is. I see that about half of individuals with bipolar disorder or schizophrenia fall out of adherence for medications, which is a huge predictor of going to an emergency room or landing in a hospital, even if it's not for behavioral health care per se. All of the other things become complicated. If you look at early causes of death for a person with SMI, a lot of that is related to accident and injury because of getting in situations that may have been preventable with the right evidence-based care. So we really work to focus on that. And then by knowing and understanding SMI and having care managers who know how to work with individuals with SMI, we can better help navigate those folks through the medical system. I'm still a provider. I work at an FQHC with a team, and I can tell you by having that kind of integrated clinic sitting inside a medical clinic that takes care of individuals laden with social determinants of health and chronic mental illness, it makes a huge difference to bring in that. So using kind of those experiences and building models at Magellan to help us scale that nationally is one of the places that we're moving into the future.
Great. That's great. You both highlighted that there are great benefits to implementing BHI within these arrangements, but unfortunately, we know that that's not always the case. It's not always smooth sailing. So Dr. Wilson, I'll start with you again. What barriers or challenges have you all encountered with your arrangement, and how have you worked to overcome them?
So the challenges that led us to implementing integrated behavioral health were primarily an external Med-Advantage mental health provider network that lacked the capacity to care for our patients. The workforce was just not there. In an effort to improve access to effective behavioral care, CMS expanded the workforce rules and definitions to include roles that previously provided essential services such as psychotherapy and group therapy, but could not enroll as Medicare providers. And our patient population is mostly Medicare patients with some dual eligibles. So that opened up the workforce. However, that also set up a competitive pay environment. And also, since the pandemic, the flexibility that we have now with the work environment we didn't have prior to 2020 has also made accessing appropriate behavioral health specialists to care for our patients, and including our team. We think primarily it is important for our patients to have a person that they can see in person. So we try to limit as much as possible virtual visits with our providers. And so that has made it a little bit complicated. We do try to be creative with how we do that, but we are primarily an in-person driven model. And so we want to make sure we bring in the appropriate people and make sure they're in center. Another challenge for us is probably the age-old challenge of engagement. We work, like I said, with a population that has had very complicated trust relationships with healthcare. Having and health literacy can also sometimes be a problem. And so having them understand the importance of engaging with primary care and engaging regularly, and then having them buy into our model, and that if they buy into really wanting to drive their own healthcare is always been a challenge, even in what you can call traditional primary care, where you're talking about the physical part of managing their health. Mental health brings a little added complexity to that. So engagement is an issue. And so we do lots of outreach, make sure we do a lot of education of our patients, and to drive that engagement higher, because we can only truly help them if they are engaging with us. Interestingly enough, though, we do have some patients who come in and will engage with their behavioral health specialist more than they will with their clinician, and we leverage that relationship to have them also engage with us, so we can kind of help manage their diabetes and hypertension, et cetera. Other challenges, and I alluded to it earlier, is the fact that as clinicians, I just don't know that we do a really good job training folks who are going to go into primary care to manage really the level of mental illness we have in our communities right now. I just don't think we do a good job. And so what we've had to do in order to make sure that our patients are getting the care and the standard of care that we want them to have is to really invest in our teams, education, resources, re-education, making sure that we have that carved out time that they can coordinate care with the behavioral health specialists, with our psychiatrists, with the social workers, et cetera, to make sure that we are really understanding all the moving parts, and and the clinicians feel empowered to really manage with some assistance and coordination these really complex patients and their mental illness, because only in being able to do that will we be able to make them not healthy physically and mentally.
That's perfect. And Dr. Carney, how about you all at Magellan? What's some challenges and barriers that you've all encountered, and how have you potentially overcome them to date?
It's a terrific question, and I would love to say there are none. However, there are a couple that really strike me coming from a payer perspective as big challenges. The first is getting data. In health plans, data sit all over the place, and it's like the statement, all of this water, but nothing to drink. We have pharmacy data coming from PBM sitting in one pocket, and medical claims and pharmacy or behavioral health claims. Data are all over the place, and they're really important to bring together in addition to real-time data to really be able to model out who needs care and when they need care. So overcoming that with tools where we can more directly outreach to people when they're not in getting a service and creating a claim. Using information like health risk assessments and screeners for social determinants of health. Those often are the greatest predictor of who needs help and when they need it. So really being able to bring together data for predictive modeling and using data for real-time interventions as close as we can get to it. And then the second is, as a payer, I often feel like we can't get upstream far enough to be able to help folks. So if I know an individual is coming in because they have a medical complication of using alcohol, if I could reach that individual while he or she was still in an acute medical setting, I could then better assist the journey in getting the right treatments and getting interventions for the behavioral health side of care for that member much sooner than they can get today. Often in an inpatient setting, it may be that someone gets a behavioral health or a psychiatric visit, consultation liaison visit. maybe not. And so they fall through the cracks. And if we can get to individuals earlier in that acute setting, I think it will be an even bigger impact on morbidity and quality of life that individuals feel, because we can get those services to them earlier. But there are all sorts of barriers that are out there in data sharing and notifications and that kind of prevent what might be best practices from going into place. And that, about that, it's the when can you share data, who can you share data with, all of that becomes challenging. But it's critical to making this work.
No, definitely. I think that's a key piece that a lot of people worry about. They're not sure whether they can share the information. They feel like they should. It would help with patient care, but they know there are rules and restrictions in place. So that's a very good point. And so I know, Dr. Carney, you had kind of touched on some enhancements that you are working on currently, or things you would like to see in the future. Why don't you talk a little bit more about that? And then Dr. Wilson will turn it back to you.
So I showed in one of those earlier slides the dashboards that have actionable data that we can give back to providers, that I think it's critical to continue to grow those programs, even if providers are not in value-based programs, being able to share that kind of data back with them. We do that in our pharmacy management programs for behavioral health pharmacy, and even when providers graduate from the program, they still stay in contact with us to get help in managing. So getting that kind of actionable data back to providers is something that we're continuing to move forward and adding into more of the work we do. I would really love to see some of that upstream work that I talked about happening, but I think the biggest area that we worry about, whether it's in value contracting or outcomes in general, is that behavioral health is really, really complex. And the kinds of enhancements we need for attribution, for what outcomes matter, what metrics matter, do process metrics matter? A lot of process metrics out there in BH, but when does the true outcome occur? There's so much work that needs to be done in this. And then finally is just configuring claim systems and the kind of nuts and bolts of paying for healthcare to be able to really create these unique models of capitation or bundles or whatever those might be in the behavioral health setting, because that's not been done. I think as a field, we're really in catch-up mode to bring some of what might be a DRG or a bundle in the physical health side over to behavioral health.
Great. And Dr. Wilson?
Yeah, I agree with everything Dr. Carney said. As we grow over time at Oak Street Health, we ask ourselves, how do we continue to do this work, see the outcomes we've been seeing, see better than those outcomes, and how do we scale that? I personally think, and I think we're moving that direction, where some or all or parts of it need to be standardized across the board. And how do we do that? And it's going to be tech. Tech's what's going to, I think, help the situation. So some sort of tech-enabled integration, more than what we have now, I think, is what I would like to see. And I know that we're working on as an organization. So what does that look like? Currently, we have Canopy, the tech platform I referred to earlier. And we all work out of that as clinicians, the behavioral health specialists, the psychiatrists, the social workers, everybody works out of the same platform. And so we can see all the individual panels and what's happening. But what we don't have is some prompting that I think would be helpful, because people do fall through the cracks for a variety of reasons. And I think this work is too important for us to allow that to fall through the cracks. So prompting that leads us to, okay, some of that predictive modeling that Dr. Carney was mentioning about, if we could do that so we can know who is most at risk, so therefore we can maybe proactively reach out to that person and bring them in to be assessed. If we have already identified them, but they have not enrolled, how do we continue to prompt clinicians, team members, to make sure that we are continuing to outreach to that person and get them involved? if they're enrolled and they've off cadence or not on track or whatever the case is, how do we continue to support our clinicians and our team members so that we are not allowing patients to fall through the cracks and not receive the kind of care that we think that they need. So for me, I think tech-enabled integration is what I'd like to see more of, and we are working on just so that we can just be able to help more and more patients, not just physically, but mentally, and just really take care of them when they come in to see us.
That's great. Awesome. And then from your perspective, we'll start with you, Dr. Wilson. What does the future of value-based care and behavioral health integration look like? So this could either be your ideal of what you would like it to look like, or where you think it's going. Both would be appreciated.
I would like to. We've done, I think, as an industry, a decent job of focusing on access. We're looking at equity. We want those folks in more challenged neighborhoods to be able to access mental and physical health as much as and as often as they can in the less challenged communities. But I think we should now start doing better at evaluating quality of the care that we are providing as well. We need to get good at being able to ensure that what we're providing is working, and if it's not, how do we change that and iterate on the care, make it more, tailor it more to that patient, et cetera. So ideally, I think it's great. We should never not worry about access and equity, but I think we also, as we do that, I think we should spend more time also evaluating quality, recognizing that it takes a team to do this work. Let's make sure that the team that we're pulling together has the education. We can invest in upskilling and supporting them in all the things that they need. We need to really, I think, just invest more in this area. And if we want to continue to provide a higher and higher standard of care for our patients.
Great. And Dr. Carney, how about you?
In integrated care and value-based models, I referred earlier to two critical points that I think are barriers to the industry as a whole. Attribution, and then are we looking at the right outcome metrics? And attribution is critical in value models. Who created the value? Who created that outcome or failed to create that? And it's really challenging in behavioral health in particular for two reasons. The model of care is not a model of care, it's multiple models of care that involve multiple types of providers. A patient's journey might begin in primary care with a prescription and end up with a psychiatrist or a therapist. Who do you attribute that case to? When it's more challenging even to attribute it to a team if, unlike Oak Street, most models don't have integrated behavioral health in the same way that Oak Street does. And so it's that attribution becomes really problematic and challenging in behavioral health. The second is, unlike, say, treating diabetes, where we can follow hemoglobin A1Cs and blood pressure and the creatinine level for individuals, there are no such labs or biomarkers available in behavioral health today. So getting to that outcome is important. And many of us would say the PHQ is just not good enough. The PHQ is a screener for depression. It doesn't necessarily say over time, does that person actually feel better? Are they now activated to live their lives fully and be in all the roles that they want to be in? What's the outcome? Who measures it? Is one screener the right thing, or do we have to look at that really in a different way going forward across different domains and scales of quality of life, as well as symptom reduction for behavioral health? So I think those two things are areas where as a country we need to grow. The Kennedy Forum right now is bringing together a diverse group of academics, providers, industry folks to deal with these issues in looking at where the data come from, who is responsible for those metrics, who do we attribute to, and what are the right outcomes depending on where an individual falls in line. And so there are groups at a national level really focusing on these efforts right now, which is critical to do. Quality has to be more than a HEDIS metric in terms of outcome. And so this work that the Kennedy Forum is doing is really focused on that. And then finally, I think because so much care is being delivered in a variety of settings in behavioral health, including primary care, how do we look at holistically that individual's journey of care and what starts an episode, what stops an episode, who's pulled into it, what are the right measures? It's challenging, but many folks like those folks at Oak Street, like Magellan, like others, are really invested in getting this right.
And we appreciate it. We wholeheartedly appreciate it. Since we're coming to the end of our time for today, I was just wondering, does anyone have any last minute thoughts they want to share with our viewers? Any key takeaways or things folks should consider?
I would love to jump in and say that I think the best outcome coming out of COVID has been a reduction in stigma against behavioral health. We have seen double-digit increases in penetration into outpatient services, which is exactly what should be happening. You know, I happily want people to come in and get the right kind of outpatient care, and that reduction in stigma is huge. Delivering that kind of service in a variety of settings, whether it's in primary care or the behavioral health setting or through telehealth or through an app, ensuring that is good care and people are getting to the right outcomes is critical. And so really thankful for having the discussion today. Thank you.
I would double click on that. I completely agree. It has been fortunate as a consequence of a really awful time in the last few years, but it has been a long time coming. There is so much that has happened and so much more that needs to happen in this area. I would like for folks to really not shy. It's hard work. It's complex work. There's a lot of things we have not yet figured out. We're not nearly as far along as we are with traditional quote unquote primary care. And we're just looking at physical conditions. But I think this is really important, and it really will make how we care for patients and the care that we give them on the physical side so much better if we just do this work and do it well. So I wholeheartedly agree. We have so much has happened, and we just have so much more to go. And I would encourage everybody to think about how to, on some level, integrate, coordinate care for their patients and really dig into this side of their care.
Great. All right. Well, thank you both for sharing your experience and expertise with our viewers. And we will have some closing thoughts here from the BHI Collaborative. To our viewers, if you have any questions about today's webinar, please feel free to contact us at practice.sustainability@ama-assn.org. And if you're interested to see the BHI Collaborative's full listing of webinar offerings over the last couple of years, please use the QR code on the top of your screen, and you can access our YouTube playlist. Please also check out the recently updated BHI Compendium, which serves as a tool to learn about behavioral health integration and how to make it effective in your practice. This updated copy has an expanded version with financial sustainability pieces and some updated case studies. You can also check out the AMA strategic guides for practical strategies and actionable steps for implementing specific topics associated with effective behavioral integration. This includes pharmacological treatment, care for substance use disorder, suicide prevention, our BHI workflow guide, the practice guide for integrated behavioral health care for older adults, as well as billing and coding. And last but certainly not least, thank you all for tuning into today's webinar. We hope that you found this session informative. And if you would like to register for more upcoming webinars in the series, please use the QR code on the top of your page. Thank you so much.